PrEP Clinic. I'm the PrEP and STI Clinic Coordinator for Medical Advocacy and Outreach. And this presentation is PEP versus PrEP, an overview. Okay, I have nothing to disclose, but we will be discussing medications, but no off-label use. Except in one instance, and I will be using brand names at times, so just bear in mind that a lot of these are complicated names and that they do have initials that we go by a lot of times. Just a couple minutes on my background. I was in college health for over 20 years, and I'm board certified in that. I'm also certified in travel health. I'm currently working on a certification in cultural competency, so I have a wide variety of interests. I have done lots of presentations on the LGBTQIA plus community and their access or barriers to care, and I only recently came to medical advocacy and outreach about a year ago to open this clinic. Having a little trouble advancing my slides, but we'll get there. The objectives of this presentation is that you be able to define the differences between PEP and PrEP as an HIV prevention method, list the populations that can benefit from PEP and PrEP, and be able to list strategies for engaging patients in this prevention method. Some of this involves having uncomfortable conversations with patients, but it is very valuable for sexual health, and it's very valuable that people know that this exists and that we can actually prevent HIV. Okay, at the end of 2019, an estimated 1,189,000 people did have HIV, and that was people age 18 and older in the United States, and that includes about 13% of an undiagnosed people with infections that have not been diagnosed as of yet. And this was estimated under the HIV incidence and prevalency in the United States for 2015 through 2019. So that's pretty amazing. And what's even more amazing is when you look at the disproportionate populations that are affected by HIV. Within the South, we make up more than 50% of new infections and new cases. And the reason that is there's an inequitable coverage of PrEP, meaning, there's people that need it who are uninsured or insurances are not covering it. But fortunately, in the last year, insurance has made this part of a preventative method. And so it is covered under Blue Cross Blue Shield and many of the other big insurance companies that we use in Alabama. It did receive a grade A for primary care for the oral medication, and we'll get to that in just a few minutes. There are some distinctions, and it should be, as far as the medication goes, covered by insurance at this point, but we do have a lot of uninsured patients that would benefit from PrEP as well. And all sexually active adult and adolescents, for that sake, should receive information about PrEP. It's very important that they get that information and it be available to them. Another thing to keep in mind is that it disproportionately affects men who have sex with men and the African American community. The reason that is not because of risk factors or behaviors that they engage in. It is more that there are barriers to care. There's lack of transportation, lack of education about PrEP, and sometimes these groups are targeted, and there's a lot of discrimination around who they are as people. So that's something that we need to be more considerate of. Okay, this is HIV in Alabama. Obviously, it shows that men who have sex with men have the highest proportion of HIV rates in Alabama. Heterosexuals come in, at a pretty strong rate. I mean, that's still significant. Infection drug users are another group, and we do have men who have sex with men as well as they are also injection drug users. And then there's a small percentage of other populations. So on the next slide, you'll be able to see how it disproportionately affects the African American community. And I need to stress that this is not because of behaviors that they engage in. It has to do with systemic discrimination against the African American community, their ability to access care, their ability to find educational resources about these types of services. Whites also, make up a significant portion. Multi-race, or, people who are of mixed race, and then the Latino and Hispanic population as well are disproportionately affected. Typically, we do not see a lot of Asian Americans with HIV. It's very, very rare. There are some growing evidence that the indigenous population, or the Native Americans to the United States, are also being disproportionately affected. But again, this is in Alabama, and this is what our numbers are showing. So if we could go to the next slide. So what is PEP and what is PrEP? Well, PEP, and I've got my little pom-poms there to advocate for it. It sometimes seems like you're putting the cart before the horse, but there's actually a difference between the two as using PEP versus PrEP. And once somebody initiates PEP, they're usually transitioned into PrEP if they're aware that certain behaviors will put them at risk for HIV. And so PEP is defined as the post-exposure prophylaxis, and it has to be started within 72 hours of an exposure, and it's usually used in emergency situations. What would that be? Well, that's in cases of rape. That is in cases where a known exposure has occurred, such as a needle stick injury with a positive patient. It can also occur if two people engage in unprotected sex and one of them discloses afterwards that they are infected with HIV. The pre-exposure prophylaxis is a daily medication to prevent HIV in high-risk populations or more vulnerable populations, and it does require regular lab monitoring. Typically, once we get people on PEP, if they feel like they're going to continue to be in situations that may expose them to HIV, they want to go ahead and transition into the PrEP program. So the journey into PrEP looks like this. So it's get ready, get set, and get PrEP. And what we definitely do is we want to have a conversation with a provider who's going to feel comfortable prescribing PrEP. And there's a lot of people out there there's a lot of providers who either don't know about PrEP or just don't know what they need to do to start prescribing it for patients. Then the thing to do is we have a PrEP navigator here at MAO who sits down, talks with the patient, tells them what to expect, and tells them what the obligations are and the commitment is to stay on PrEP. And then the next part is once their labs have been drawn, they've gone through their orientation, then they are ready for PrEP. And PrEP, again, a daily medication. It does require lab monitoring every 3 months, which is important, and we're going to talk about that next. You're going to see why we call this a little bit of a tongue twister. For PrEP, it is M-tricidabine, 200 milligrams in combination with tenofovir, disoproxil, fumarate. and the brand name is Truvada, but we do have a generic for that. The other medication that is pill form, which is daily, is the emtricitabine, 200 milligrams in combination with tenofovir and alafenamide, and that brand name is Descovy, and currently there is no generic for Descovy. And I'm going to talk a little bit about what the benefits are of both. For PEP, we use the emtricitabine in combination with the tenofovir disoproxil fumarate, and plus they add on an extra medication, the Kabbategravir, twice daily, or the dolutegravir once daily. It's up to the provider, but again, it's to get that patient to be able to be HIV negative in the event that there has been an exposure. So it's a little bit more medication, but once they complete it, it's a 28 to 30 day dosing. Once they're at the end of that, we draw some labs, make sure that they're fine, and then they can go on and if they choose to, stay on PrEP. Okay, and the next slide is new to the picture. The Kabbategravir for PrEP, and the brand name is Apretude, is an injection that is going to be given once a month for 2 months and then once every 2 months. The big thing is it can be used in men and women, unlike the Descovy, which can only be used in males. And this includes, for the Kabbategravir, we can use this for transgender males and females. Much greater convenience for the patient, and the lab requirements are not as stringent, and they can be drawn the day of injection once the person first starts on PrEP. So we're very excited to have that on the board. Okay, the next slide is a little bit busy, and it's going to go over your lab requirements. 2-1-1 method of PrEP. It is event driven, in which a patient takes PrEP 2 to 24 hours prior to sexual activity, and then 1 tablet each 24 hours following until they are no longer sexually active for at least 48 hours. So they take the initial 2 doses of Truvada or Descovy, then the next 24 hours they take 1, and then the next 24 hours they take another 1, and that continues until, like I said, they're no longer sexually active for 48 hours. So that is an off-label use of the medication, but it is being used particularly when a patient is having sex very infrequently. And something else to keep in mind when we're talking about Cabenuva, the injectable, the great thing is that we are going to be having some sub-Q injections that are on the market that are coming out, and we're going to have different options where PrEP is concerned. For PEP and PrEP. Because these are HIV medications, we have to do a rapid test at baseline for PEP, and this indicates whether or not the person has had an existing HIV infection, and if so, PEP should not be started. However, if no baseline test, a rapid test is not available, they should not be withheld from getting PEP, and the oral tests are not recommended at this time. We are using a finger stick. It's called an InstaTest, and it takes about a minute to complete. It's very, very accurate, and it's definitely a good way to go for patients who are trying to get on PEP immediately. The other things that we have to do to get on PEP, because we only have 72 hours, is we have to do a pregnancy test in all the females. We need to do some liver enzymes, the BUN creatinine, and an STI screening, particularly if this is in the, been a sexual encounter. It is something like a finger stick in the hospital or a needle stick in the hospital, then there's no reason to do, obviously, STI testing except for some hepatitis testing. You do need to test for hepatitis B. Again, this if the person has underlying hepatitis B, it can make it worse. Or if they've ever had hepatitis B, then it could reactivate. We also need to know that their hepatitis C antibody is negative. The reason for that is one of the medications in the combination is used to treat hepatitis C, and we need to know if we need to continue that or not. And then they also need a hepatitis A evaluation. In contrast, the initial clinical evaluation in screening for PrEP is actually the labs and then be seen by a medical provider. And this occurs even before providing PrEP. And it includes a brief history of the patient, signs or symptoms of any acute HIV or sexually transmitted diseases, history of kidney disease, and medical review, and then the assessment if they are a candidate for PrEP. What we do here in the clinic is we try to get the patient in 2 weeks prior to seeing one of the providers and get their labs drawn before they actually initiate PrEP. And we do a 4th generation HIV blood test. We test their kidney function, the hepatitis A, B, and C serology, STDs, which includes 3 swab sites, which is the oral, rectal, and vaginal if necessary, or we send out a urine pregnancy test again for women. Follow-up at 3 months is at least with a creatinine, a CMP, or a CMP, and then HIV screen. And then at 6 months, they're going to have the STIs again, the HIV, and a creatinine or a CMP drawn. So a little bit complicated, but once you get used to it, you just find that there's a flow. What's interesting to note is that PrEP only takes 7 days to get into the penile tissues and be able to protect people, a person against HIV infection, where if they are participating in vaginal sex, then it does take 20 days to get in the vaginal tissues. So we do recommend that they are using a backup method of protection. And we recommend that anyway, because we try to explain to them that just because you're protected from HIV doesn't mean that you can't get other infections as well. So what is a PEP population? What would be a good candidate? And certainly during a sexual encounter, when somebody says the condom broke and I'm really scared, I'm not sure if the person's HIV positive or not. They told me they were afterwards, so I need to be, tested, and I also want to get on PEP. Any kind of healthcare worker who has an exposure to body fluids through, cutaneous surface, obviously an injection, a needle stick, that kind of thing. Even getting blood in the eye area would be a good candidate for this. And obviously sexual assault victims. We do want to press again that, condom usage is, kind of at a stagnant level. We try to encourage patients at any sexual encounter that they have to please use condoms and to keep that in mind. And if you'll see the ladies who are getting the shot on the other side, OSHA no longer requires or recommends that a person who's getting just a regular injection for an immunization or something, that the provider does not have to wear gloves. That is kind of up to you, how comfortable you feel. But I have personally only been stuck once, and it was being distracted by a patient, and I was walking across the room and was trying to get something into a sharps box, and I stuck myself. So that's just something to keep in mind, that maybe gloves, they're not 100% the answer for everybody, but keep them in mind that they do help cut down some of the exposures to body fluids. So what populations would benefit from PrEP? Okay, so anyone with a high-risk sexual behavior, that would be people with multiple sex partners, men who have sex with other men, bisexual, persons, That's just a really good baseline. But anybody who comes to a provider and says, I would like to be on PrEP, should be offered PrEP, because they know what their behaviors are, even without having to go into them and give a detailed sexual history. If they want PrEP, they should be getting PrEP. Injection drug users, particularly since we do not have good safe needle exchange programs, particularly in the South, and a partner that's in a discordant relationship. This is someone who is in a partnership with somebody who does have HIV. Even if it's undetectable, it would be a great idea for them to get on PrEP as well. Again, it is very imperative to discuss condom use in all individuals who are sexually active, because PrEP does not protect or prevent any other STIs. And another part, another big group that we don't necessarily talk about very much, but people who are in the sexual trades, prostitutes, male and female, would need to, be counseled for PrEP, and that's a good, just a good one-on-one. If they come to your facility and they disclose this would be a good opportunity for you to say, hey, there's this medication that prevents HIV. Would it be something that you're interested in? Okay. So strategies that promote prevention is starting the conversation with patients in regards to their sexual health and normalizing the perception of sex as a human part of life. It's not going away. Sex is not going to go away. It's just not. People are going to continue to have sex. And when we don't talk to our young people and our adolescents and young adults about sex and the risks that they take as far as having unprotected sex, we are going to continue to see not only HIV, but we're going to see STIs as well. And let me give you a real frightening statistic that we had brought up to the clinic yesterday, is that we administered over 135 of the Insta tests in 1 month of this year, and we had 16 positives, where typically we might have 1 or 2 in a month. So people, particularly during the pandemic, we as infectious disease people were looking at this and knew people were continuing to have sex, but they weren't getting tested, and they're being tested now, and we're going to see explosions of not only STIs but HIV as well. There's a long, long way to go in ending the stigma of HIV as an infection, as it's a sex infection, when in fact it should be treated like any other chronic illness. A person, can be undetectable and not be able to, give HIV to a partner or any other person. We call it U equals U. If there is no if you're undetectable, then there's no way you can transmit, is what I'm trying to say. So it's untransmittable. So just keep that in mind. We do have really good tools that are available to us, and I'm going to show a couple of those to you. Hopefully my slides will not get messed up when we do this. First of all, taking a good sexual history, and I've given you 3 different scripts here that you can use, and we'll just try to go to one if it'll let me see if it'll let me open it, and it's not letting me open. But you do have the CDC, which is a great source of information, and you can just type in taking a sexual history. Yeah, it's not going to let me. And I apologize for that. But the CDC, taking a sexual history PDF, it's, it's a few pages long, but you can kind of flip through it and get some good ideas. The AMA, the Patient Sexual Health History, What You Need to Know to Help, and then the AAFP document, Patient Care, on STIs. It gives you a script that you can go through, and it's very, very helpful, particularly if you're not comfortable talking about sexual health. I am, just because I've done it for so long, talking to students and now talking to people who are not students all the time. I do have a good cohort of students that do still come by, but I deal with a lot of adults, any age, from 17 all the way up into their 60s about their sexual health. And sometimes they're very embarrassed, and it's embarrassing to have to come in to a clinic and talk about these issues, but it's good for them because it lets me know how to help. Okay, on the next slide. So you need to know your audience, and you may need to change some of the things that you do in your practice. The first thing you need to do is create an inclusive atmosphere for all patients, and that includes space on forms for things like preferred names, pronouns, have literature in the waiting room and the exam rooms that promote a diversity of patients, and just know that you're providing a safe space. You can't tell just by looking at a person their sexuality, their sexual preferences, and their sexual habits. Sex is considered a normal, healthy part of life, and it's our job as health care professionals not to judge, but how to give the best advice possible to a patient. If you don't know something, if they use some terminology that you're not comfortable with, just ask. Just say, I've never heard that term before. Can you please go over it with me and, tell me what it means to you. And the other thing is, if you do make a mistake, if you're not using the proper pronouns, just apologize to the patient. Say, this is new to me, I'm trying to learn, and can you bear with me, this will help me in my learning and my growth as well. And again, becoming comfortable just taking a sexual history, you need to know who, with what, how often, or the 5 P's, which is partners, how many partners, what kind of practices are they in? Is it oral, anal, vaginal sex? What kind of protection are they using? Do they use any protection? And have they ever had a past history of an STI? Because, having an STI can increase your rate up to 500 times to be more susceptible to HIV. And then prevention. Well, what kind of prevention? Well, typically we think of pregnancy prevention or intention. Do they want to become pregnant at some point in time? Do they want to have children? If not, what can we do to assist you? And just be open-minded. There's a lot that's going on right now, almost like a sexual revolution with genders and gender identities. So the more open-minded you can be, I think that will give you the best outcome for your patient. Okay, so where to find services? You can actually click on this particular website here, and it will take you to a little box where you put in a zip code, and it will tell you where you can actually go to get PrEP and PEP services. So that's great. It can also tell you where you can get HIV services. So this is a great little tool for patients to know about. You might print that out on some cards and hand them out to patients and just say, look, if you ever need this, you can just look it up and be able to find a clinic. A lot of times we have patients that transfer across country and they want to, continue their PrEP, and it's my job to, locate a clinic or a facility that they can go to once they transition over. And I just want to thank everybody for your attention and let you know that I am available. My email address is amorris, AMORRIS @maoi.org, and I look forward to any questions that you may have. Thank you so much, and I hope you've enjoyed this.